you have access just in case the the office Wi-Fi goes out? Are you?
Yes, yes, I'm going to record it too.
Okay.
Okay, great, thank you. Okay, all right, so we're broadcasting now. VP attendees coming in. Hello, everyone. Welcome to today's webinar. We'll get started at 12 o'clock Pacific, 3 o'clock Eastern time, right on the dot. So thank you so much for joining us today. We'll get started soon. I think you messaged it too. Okay, everyone, we'll get started. Hello and welcome to today's session. My name is Joe Lee, and I am the Training and Technical Assistance Director of the Association of Asian Pacific Community Health Organizations, or also known as AAPCHO. On behalf of AAPCHO, I welcome you to today's webinar on increasing access to care and improving health outcomes, a spotlight on Asian American, Native Hawaiian, and Pacific Islander serving health centers. Oops, I'm going to transition my slides here. Great, so just before we get started, I'd like to share with you a little bit about AAPCHO. We were founded in 1987, and we are a national association of 32 health centers, primary care associations, and community-based organizations. Our mission is to promote advocacy, collaboration, and leadership to increase access to care and improve the health status of Asian American Hawaiians. We are also a funded National Cooperative Agreement, or NCA for short, to provide training and technical assistance that is data-driven and focused on quality and operational improvement to support health centers, lookalikes, and newly funded HRSA awardees who serve Asian Americans, Native Hawaiians, and other Pacific Islanders. We'd like to acknowledge our friends at HRSA for their continued investment in AAPCHO and the Health Center program. We are actually one of 20 Bureau-funded NCAs to provide training and technical assistance to all health centers nationwide. And we are tasked particularly in 3 goal areas to increase access to care, improve health outcomes, and promote health equity. And we really thank all of you for joining this free webinar that's sponsored by HRSA. Today, we're really excited to launch our newly updated report titled The Health of Asian Americans, Native Hawaiians, and Pacific Islanders Served at Health Centers, UTS 2018. AAPCHO produced this report because we like to take a closer look into AA and NHPI populations within the health center program and research how this population is changing within health centers as they are changing nationally. This report will be made available for download at the end of this webinar and can be found on our website at www.aapcho.org. We can also copy and paste the bit.ly link that you see in front of you into the Zoom chat box so that you have the opportunity to download the report right now if you'd like. So today's agenda will include a 45-minute presentation on the newly released report with a Q&A immediately following. Here are a few learning objectives that you can expect. We're going to present an overview of patient demographics health utilization, and patient health outcomes at AA and NHPI-serving health centers. We are also going to highlight for you some key differences between AA and NHPI-serving health centers and other community health centers across the nation. And lastly, we're going to discuss the implications of key trends, findings, and opportunities to improve healthcare delivery and outcomes at AA and NHPI-serving health centers. Our speakers for today's webinar are Vivian Lee, our Research Project Manager and Analyst at AAPCHO. Vivian has more than 6 years of experience in community health research, project development, data analysis, and implementation, and she is an active member and lead of our Prepare project, a nationally recognized social risk screening tool primarily used by health centers. And we are also excited to hear from Albert Eisen, our Senior Program Manager of Training and Technical Assistance at AAPCHO. He has more than 9 years of health center and PCA experience in curriculum and training development, project management, research, communications, and policy. And he's an active member and lead of our National Enabling Services Data Collection Initiative and the Prepare project. So before we get started, we're actually going to go through some housekeeping. Right now you are on our Zoom platform, and as an attendee, you can mute and unmute your audio. Right now we're muting everyone, and you can virtually raise your hand and send messages to others. So here you can click the mute unmute button to mute or use your microphone. You can click the little up arrow button on the right side of the mute unmute button to choose specific audio settings for your microphone and speaker system. During the presentation, you may ask questions at any time. So click the Q&A box at the bottom and type your questions into the open field. The moderator will either send a typed response or answer your questions live. And attendees can also upvote or and comment on open questions, as you see in the example in front of you. You can also click on chat to communicate with all panelists and or attendees at any time during the presentation. And you can chat us for any troubleshooting. So that looks like that right there. And let's see, if you have a question during the Q&A time, you can click raise hand and the moderator will be able to open up your audio for you to ask a question. Afterwards, you can click lower hand to be dismissed. And then when you leave the webinar, if you want to leave the webinar, you can click leave meeting and you'll be prompted to complete a short post-webinar survey. Your webinar makes a difference for us to provide high quality training and technical assistance for future events. So we really encourage you to take this webinar. Okay, so before we get started, we're actually going to ask a few questions for our wonderful audience today. Our first question today is, which of the following best describes your organization type? If you can answer the poll, are you a community health center, a primary care association, a national cooperative agreement, or an HCCN, government, academic institution, social service or community-based organization, or other? And we are going to give you a moment to vote. Great. Looks like about half have voted. We can close the poll now. So for our national audience today, if we can share the results, it looks like the majority of our attendees are community health centers, FQHCs and lookalikes. So welcome. And we have a lot of folks representing government and CBOs. Great. We have another couple of quick questions for you. We're going to launch the second poll. Does your organization work with or focus on Asian American, Native Hawaiian, and Pacific Islanders? So let's see if we can share that poll. Actually, let me stop sharing here. Ooh, actually, apologize, everyone. It looks like the poll is not set. Oh, is it there? Give us one moment.
They answered all the questions.
Oh, they already answered all 3 questions. Oh, okay. Oh my goodness. Sorry, everyone. I didn't realize that you all answered the questions. This was a single poll. So does your organization work with or focus on Asian American, Native Hawaiian, Pacific Islanders? It looks like majority of you said yes. And for health centers, do you have new populations or growing populations of AA and NHPIs in your city, state, or region? It looks like many of you said yes. Some of you are unsure. And this is, for majority, this is not applicable, which is A-OK. Okay, all right, we're going to move on. Thank you, Christine. Okay, so without further ado, I'm going to hand it over to Vivian, our research project manager and analyst, who's going to give you a spotlight on our AA and NHPI serving health centers. All right, Vivian.
Great, thank you, Joe, and thank you all for completing the polls. So in the next few slides, I will go over the findings in our report. The reason why our report focused on Asian American, Native Hawaiian, and Pacific Islander, or AA and NHPI serving health centers, is because this population is among the fastest growing racial groups in the United States. The AA and NHPI population in the US is projected to grow from about 15 million in 2005 to about 40 million in 2050. Also, AA and NHPIs are diverse within the group, consisting of more than 50 ethnic groups and over 100 languages. So in 2018, almost 1.3 million AA and NHPIs received care at federal qualified health centers, or FQHCs, and this is a 123% increase from a decade ago, and about a 5% increase from last year, the 2017. So in our analysis and in this report, AA and NHPI serving health centers are defined as the top 10% of the 1,362 health centers in the 2018 UTS report, in terms of the number of AA and NHPI patients served at the health centers in 2018. Therefore, a total of 136 health centers were identified as AA and NHPI serving health centers. We used the number of AA and NHPI patients served instead of the percentage, because the resources that a health center dedicates to a group of patients is more related to the number of that group of patients. The averages you will see in the next few slides were calculated using the raw UDS data. And also, to determine significance, 2 sample t-tests were conducted at significance level of 0.05. In 2018, the top 5 states with the highest number of AA and NHPI served by health centers remain the same as in 2017. They are California, New York, Washington, Hawaii, and Massachusetts. The number of FQHCs in these 5 states mostly remained the same as well, except for in New York, the number of FQHCs decreased by 3. In 2017, it was 65. So the top 5 states in terms of number of AA and NHPI served by FQHCs have been consistent in the past few years, and they are the states traditionally known as having big AA and NHPI populations. And we will look more into the new growth states in the next slide. So in 2018, compared to 2017, states that experienced new growth by the raw number of AA and NHPI served at health centers include California, New York, Colorado, Texas, and Massachusetts. However, when we look at new growth states by the highest percentage change from 2017 to 2018, that list includes Colorado, Texas, Arizona, Rhode Island, Nebraska, and Ohio. In this slide, we compare patient demographics between the four groups, which are the AA and NHPI serving health centers, the national health centers, the general US AA and NHPI population, and the general US population. Compared to the National Health Center average, AA and NHPI serving health centers serve a statistically significantly higher proportion of AA and NHPIs. Patients with limited English proficiency, low-income patients, patients on Medicaid, and publicly insured patients. In contrast, the proportion of uninsured patients seen at AAPCHO serving health centers is slightly lower than the National Health Center average, which may be attributable to Medicaid expansion and insurance marketplace enrollment efforts under the 2010 Affordable Care Act. Overall, AA and NHPI serving health centers serve more Medicaid and publicly insured patients when compared to national health centers and compared to the general US population averages. This slide shows the comparison between average enabling service staff full-time equivalent, or FTE, between the AA and NHPI serving health centers and the national health centers. The most notable differences between the two groups can be seen in the National Health Center's provision of enabling services that support access to healthcare and improve health outcomes. The greatest differences are seen in enabling services provided by case managers, patient or community education specialists, and eligibility assistant workers, where the FTE rates are nearly double or triple that of the National Health Center average. AA and NHPI serving health centers their employees are predominantly multilingual workers, and some may serve as high as 99 to 100% of patients with limited English proficiency. Some AA and NHPI serving health centers provide services in over 15 languages. According to the 2018 UTS data, there are 4 AA and NHPI serving health centers in total that serve 99 to 100% LEP patients. And on the National Health Center level, there are 21 health centers in total that served 99 to 100% LEP patients. So in general, the enabling services data, such as interpretation or translation, are not always captured to reflect the actual volume and intensity of interpretation services provided at health centers. Therefore, interpretation staff at health centers may report lower than expected FTEs due to the lack of documentation. For AA and NHPI serving health centers, interpretation staff may consider interpretation and translation as part of their role and daily duty, therefore may not always track these essential services. Overall, AA and NHPI serving health center enabling services FTEs are higher than the national average, but more information is needed to better understand these differences. This slide shows the comparison on some quality of care measures between AA and NHPI serving health centers and the National Health Centers and the Healthy People 2020 goals. Despite the high social determinants of health barriers and disease burden of their patient population, the AA and NHPI serving health centers have statistically significantly better screening rates and health outcomes for childhood immunization, cervical cancer screening, colorectal cancer screening, and controlled hypertension when compared to the National Health Center average. These relatively better health outcomes may be partially due to the substantially higher volume, a higher number of enabling services provided at these health centers. With the exception of controlled hypertension, neither the AA and NHPI serving health centers nor the national health centers meet the Healthy People 2020 benchmark goals for childhood immunization, cervical cancer screening, and colorectal cancer screening. This warrants an effort to increase the nation's quality of care for these preventative care measures. So in this slide, the graph shows a comparison on diabetes and hypertension outcomes on the National Health Center level between the white population and the three ANHPI subgroups, which are Asian Americans, Native Hawaiians, and Pacific Islanders. The specific subgroups within the ANHPI populations at health centers demonstrate greater health disparity, which are often masked when observing diabetes and hypertension outcomes of ANHPIs collectively and comparing them with the white population. Most notably, the Native Hawaiians and Pacific Islanders had higher rates of uncontrolled diabetes and uncontrolled hypertension on average when compared to Asian Americans and the white population. When comparing diabetes and hypertension outcome between the AA&NHPI-serving health centers and the national health centers, our analysis show the Native Hawaiians and the Pacific Islanders also had overall higher rates of both uncontrolled diabetes and uncontrolled hypertension. In addition, the average rate for Asian Americans with uncontrolled diabetes in the ANHPI-serving health centers, which is 19%, as you can see on the graph, is lower is lower when comparing with the National Health Center. This difference may be attributable to the increased screening for diabetes at a BMI of 23, since Asian Americans are at risk for type 2 diabetes at a lower BMI. It may also be a result of aggregating Asian American ethnic groups. For example, studies have found that Filipino, followed by Koreans and South Asians, had higher rates of diabetes compared to other Asian ethnic groups and Caucasians. So in summary, health disparities may be masked in the Asian American racial group because Asian American subgroups are often aggregated into one. And when the data is disaggregated, health disparities become more apparent. There are some data limitations with our analysis. First, the UTS data is health center summary data, not patient level data. So we needed to use health center average for comparisons. And we were not able to make direct comparisons between populations except for the diabetes and hypertension outcomes. Second, the UTS data is aggregated level data that may mask potential health and demographic differences amongst AA and NHPI populations. And last, only 3 health outcomes, which are diabetes, hypertension, and healthy birth weight, are disaggregated by race and ethnicity in the UTS. Therefore, we were not able to make population-wise comparisons for some of the other very important measures. So here, these are the findings from our report, and I will hand it back to Albert now.
Great, thank you so much, Vivian. So before we actually go handing it off to Albert, I just want to thank you so much for that great overview, Vivian, of the changing demographics of the AA and NHPI populations being served at health centers nationally. And you also provided a really nice reflection of our enabling services workforce and our quality of care, the state of quality of care, particularly around diabetes and hypertension outcomes. And I would really like to just emphasize that point you made earlier, why it's so important to disaggregate AA and NHPI data to unmask health disparities across all the subgroups. So with that said, I'm really excited to hand it over to our next speaker, Albert Eisen, who's our Senior Program Manager of Training and Technical Assistance at AAPCHO, who will provide you a quick summary of our findings, as well as recommendations moving forward. So Albert, I'm going to give you the mouse and keyboard control. You have it now.
Thank you so much, Joe, and thank you, Vivian, as well, for providing that really detailed analysis. Had a pleasure of working with Vivian over the last few months and the rest of the team to really develop some key summary and recommendation points for you all here in the virtual room today, especially for the House Centers. We want to be able to take some kind of distilled lessons learned from our analysis and have you kind of operationalize it moving forward, especially with a data-driven perspective, now that we're all in this data-driven culture in the House Center space. So before I go into the table here, just want to emphasize that the provision of non-clinical services, which we call enabling services, are critical to improve the clinical quality and patient health outcomes for the AA and NHPI patient population. And it's evident from some of the analysis that Vivian and the team did in the AA and NHPI-serving House Centers nationwide. The UTS 2018 findings suggest, again, that the higher quality health outcomes may be attributed to the significantly higher number of enabling services that do assist in the prevention and management of chronic and infectious disease conditions, including diabetes, hypertension, and hepatitis B. This is especially important for AAPCHO and you all because AA and NHPI-serving House Centers are on the front lines serving the medically underserved AA and NHPI population, and they can provide models for delivering comprehensive quality health care that is culturally and linguistically appropriate. So in these next two slides, I was able to distill, again, 6 key findings that you will also find in the report. And the first one being that there is a growth and geographic distribution of AA and NHPI populations across the US and not just in the West or East Coast states that we are normally accustomed to. As Vivian had alluded to earlier, there's some states like Nebraska, Ohio, Arizona, Colorado, so the middle of America that we're seeing a growing population of the AA and NHPI population at House Centers. And so for House Centers in the room, again, what does high quality of care look like for serving this population? It includes, again, research and data to disaggregate this population on a House Center level. It also includes comparing the national House Center data to your own data sets so that you can really drive some programmatic and operations for your House Center and patients. So that's one big takeaway. The second one is there is a higher concentration of Asian Americans and Native Hawaiian Pacific Islander patients with more complex health and social medical needs. And so in order to address that complexity, AAPCHO has really emphasized the importance of class, or the culturally and linguistically appropriate accessible services that is often promoted by the Office of Minority Health under HHS, just really focusing on the nuances of the different subgroups within the Asian groups, for example, and also distinguishing between Native Hawaiians and Pacific Islanders, since they have historically had different just needs. And then secondly, fostering community partnerships if you're unable to provide all the services in-house at your House Center, especially with housing, transportation, language access. We understand and acknowledge that House Centers may have it or may not have everything at their disposal. So definitely promoting your partnerships and creating memorandum of understanding or just data sharing across your community is really important to understand your population as a whole. The third takeaway is that there are a greater number of enabling services staff at these AA and NHPI-serving House Centers, and some of these House Centers that AAPCHO has been privileged to work with are really operationalizing enabling services data through our standardized data collection toolkit, which is also available on our website. This data collection toolkit really digs deep into some of your FTE workforce. So for example, your community health workers or health educators are able to drill down on the number of minutes they're spending with a patient and also the intensity, or in other words, the volume. To put it differently, you might have a health educator working with one patient for 60 minutes, and they might be seeing that patient 4 times a month. So again, volume and intensity are really important data sources to look at, to really think about the workforce needs and investments you need to make at the House Center level. And so if you go into that toolkit and data collection protocol on AAPCHO's website, you'll really get a good glimpse of how to operationalize enabling services data. Oh, sorry, just too many slides ahead. And three more takeaways from the report is that NHPI-serving house owners have higher quality of care. And as Vivian had alluded to, this really focuses on the fact that NHPI-serving house owners and some of AAPCHO's network members are really focused on the enabling services and SDOH needs of their patient health outcomes, their patient health population. Correct me if I'm wrong, sorry. We are focused on high quality of care in the context of enabling services and social determinants because of the changing healthcare landscape around value-based healthcare and also alternative payment models that may be discussed at your state or local level. And so AAPCHO has been really focused on providing better data, and we've recently started doing more risk stratification of patient populations at health centers using the social determinants of health, and in particular the PREPARE data that the research team in AAPCHO and NAC and the Oregon Primary Care Association has been focused on for the last several years. And so they are talking about risk stratification now, and hopefully we'll be talking about risk adjustment in the near future. And this really all relates to just being able to advocate on a policy level and systems level for better reimbursement for some of these enabling services, such as interpretation and translation. The fifth takeaway I wanted to highlight is that the health disparities are often masked when these subpopulations are aggregated or combined in data sets. And so in order to really understand your health needs of the ANHPI population, as Joe and Vivian mentioned, we want to focus on disaggregating that data as much as possible by different ethnic groups within the Asian and Native Hawaiian Pacific Islander subgroups. And that could be done on a patient level, on a health center level, and also through some of the other data sources coming through at your health center or organizations. Lastly, the sixth takeaway is that we are seeing higher rates of hepatitis B and tuberculosis rates. The report will show that hepatitis B rates are higher in NHPI-serving house centers compared to national house center average, and also compared to the US general population. For TB, the health center data doesn't show much difference, but when you look at the CDC's data, which is footnoted in our report, we are seeing that Asians who are particularly foreign-born are more at risk for hepatitis B and TB. And so we really want to emphasize the importance of implementing high-quality standards of care and clinical guidelines that really improve your patient's health outcomes around these infectious diseases. So in the report as well, we have these recommendations at a very high level. They include, again, disaggregating race and ethnicity data, improving population health management, leveraging local, state, and or regional resources, increasing SDOH screening and standardized data collection, ensuring access to health insurance, demonstrating the value of enabling services staff, and informing the standards of care. So at the end of the report, if you're able to take a look at it today or in the near future, you'll see some kind of key talking points that you can discuss or bring back to your staff and your teams and partners who are working on some of the NHPI health issues. This is just another visual and key takeaway based on some of our big HRSA projects, really increasing access to care. And it really starts with data. If you don't have the data, you can't really prove what the needs are. And with a lot of the federal funding out there, they're really asking for some of that social risk data, for example. And tied to that is also the enabling services data. So what are you doing to address some of the social risk factors such as housing, transportation, or food insecurity? And what are you doing to respond or intervene? And so the interventions piece is huge. And the enabling services data collection toolkit really focuses on some of those key interventions like care coordination or case management that your health center staff may be providing but not documenting regularly or frequently. And we already mentioned disaggregated data again. And love this quote from Edward Demings. Again, without data, you're just another person with an opinion. So data, data, data. This is hard in practice and in theory. So the more you can get your staff to really buy into just standardizing data and loving data, I think that's one of the best lessons learned when working with health centers is they have a clinical informaticist or chief information officers who are really spreading awareness on just the importance of being data-driven and data focused. Another big high-level takeaway is just improving health outcomes. As previously mentioned, the U.S. Preventive Services Task Force has some screening guidelines for both hepatitis B and latent tuberculosis infections, and so those are available on their website. And then for diabetes, especially, we have new guidelines that were promoted starting in 2015 on screening Asian Americans at 23, and that's available on the website at screen@23.org if you're interested in learning more about that. And of course, expanding and focusing on evidence-based care models like PCMH and the chronic care model is still relevant to this day so that we can be patient-centered when we are addressing the needs of our patients. And lastly, promoting health equity. In the context of health equity, just thinking about the built environment and how really where patients live, work, play is really important and influential in their health outcomes. And so it's really looking at the upstream effects of how patients are manifesting some of their health conditions, stressors, and deficiencies, and also looking at their medical needs as well, since again, treatment and prevention are equally important. And we're seeing a lot of that conversation shifting in the state level when we're talking about value-based payments or alternative payment models. And so if you're interested in learning more about kind of which states are taking kind of lead or charge on alternative payment models, we'd love to have some conversations, and please reach out to us so that way we can learn more from you, and we can also provide you with some national level information on that changing landscape. Again, please download the full report and you'll get more details on some of the analysis and recommendations that we were just mentioning. And with that, I will pass it on to Joe.
Great, thank you so much, Albert. I'm going to change our settings here. Okay, thank you, Albert, for providing a summary of the report's findings. And I certainly want to emphasize your point on how important it is for health centers to continue providing culturally and linguistically appropriate services as the Asian American and Native Hawaiian Pacific Islander populations continue to grow with complex health needs. And we are honored by the many health centers online right now who are leaders and champions in this area. And if you are a health center actively serving an AA and NHPI population and working on particular innovations, please let us know. We would love to highlight your work. Albert has also mentioned the importance of collecting standardized data so that we can truly understand the needs of the patients we serve. And with this data, we can actually take action by allocating appropriate resources for health centers to respond to these needs. And on a more systemic level, use this data for policy advocacy. So in the next section here, I'm really excited to share with our audience today some resources, some valuable tools and resources to assist health centers and organizations that serve AA and NHPI organizations to help both evaluate and build their capacity to enhance data collection and operationalize these best practices in cultural and linguistic competency for this population. So first up, here is a free resource. That is right, folks. This is free, F-R-E-E. This is our Enabling Services Data Collection Toolkit. For some of you who may not know or may not be familiar, enabling services are non-clinical services that aim to increase access to healthcare and improve health outcomes for the patients we serve. So enabling services includes things like transportation, interpretation, case management, health education, and so much more. And we know that as health centers, there is such little data available around the impact of enabling services on QI and health outcomes among the populations we serve. And because the value of enabling services has not been demonstrated by existing data, enabling services have not been reimbursed or adequately funded by payers. So this continues to be a challenge today, and it is AAPCHO's goal to really change that financial situation and landscape. So this is a tool that you can download today, enablingservices.apcho.org, where you can do a needs assessment, a readiness assessment, and look at some of your existing workflows. What are you doing to collect standardized enabling services data to capture the impact and value of your enabling services? Next up here, you'll see the Prepare, Implementation, and Action Toolkit. So PREPARE is an acronym that stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. Whew, that is a long name, but it is a great acronym, PREPARE. It's a national effort to help health centers and other providers collect the data needed to better understand and act on their patients' social determinants of health. And we are actually very proud to announce that PREPARE is now the most commonly used social needs screening tool by Medicaid managed care organizations across the country. In this toolkit, which is also free for you to download today, you'll find 10 chapters focused on data collection preparation, collection, assessment, and responding to data. And we are also excited to share with you that our PREPARE assessment tool is translated in Arabic, Burmese, Chinese, both simplified and traditional, Korean, Tagalog, Vietnamese, and more. And if there are more translations needed, please let us know. This is a stakeholder, health center, and patient-driven toolkit, and we would love to hear from you on what other translations or needs you might need. So as a limitation, many of you have heard from Vivian and Albert that UDS has its limitations. However, we are excited about this new change. There's a new UDS question for 2019. And if you just Google UDS 2019 manual, you'll see on exactly page 175 under Appendix D, the health center HIT capabilities, there are two questions where question 11 asks, does your health center collect data on individual patients' social risk factors outside of the data reportable in the UDS? And you have a few options. Yes, do you collect data? No, but we are in planning stages to collect this information, or no, we are not planning to collect this information. And there's a follow-up question to this. Which standardized screener or screeners for social risk factors, if any, do you use? And you can select from a list and prepare the protocol for responding to and assessing patients' assets, risks, and experiences. Prepare is an option for you to select that tool if you are using that, as well as any other screening tools. So this is actually really exciting because as a national association, any data, new data that we receive around this, we can better assess who is and who is not collecting data and who may need some capacity building services to be able to collect the standardized data. And lastly, I would like to share with you the Office of Minority Health's Think Cultural Health initiative, where they're promoting the national class standards. These are 15 guiding action steps, and they're really intended to advance health equity, improve quality, and help eliminate healthcare disparities. And you'll find that there are some principal standards that may be applicable for your organization. How do you strengthen your governance, your leadership in the workforce, your communication and language access, and how do you, really embrace continuous improvement and accountability for your organization? And I'm really happy to see here that Office of Minority Health has translated these class standards into Mandarin or Chinese, Vietnamese, Korean, Tagalog, and more. This is a resource that AAPCHO provides for all health centers working with immigrants, asylum seekers, migrants, and refugees. At AAPCHO, we really believe that healthcare is a right, not a privilege, and that everyone must have access to affordable quality care regardless of language, culture, and immigration status or ability to pay. So in partnership with numerous regional and statewide and national associations, we are a proud partner to address issues like the public charge that impact access to care and health outcomes of the most vulnerable populations we serve. So with that said, you just received an overview of our report, our summary and recommendations, as well as some tools and resources that are free and accessible to you today. And we are going to spend about the next 5 to 10 minutes answering questions from our audience today. And our wonderful moderator, our co-host, Christine, has been fielding some of the questions. If you can look under on your Zoom control, click on the chat box Q&A. And if you type in your question under Q&A, we can either answer it live or type in a response. And I see that some folks are maybe chatting on the chat box, but we do encourage you to type it in the Q&A box. So what are your questions and what are your thoughts? So our first question here is there a list of, oh, looks like that was answered. Yes, of course, Kelly, looks like you raised your hand. Let's see if you, feel free to talk into the microphone or phone. Okay, we are not hearing from Kelly. That is okay. We have been answering some questions through the Q&A function. If you see the Q&A chat box, you may see a response where folks are asking if, an AA and NHPI-serving health center is a health center that serves all ethnic groups. Yes, absolutely. These are health centers that serve all ethnic groups, just more AA and NHPI patients. Folks are asking where they can get a copy of the recording, as well as webinar slides. We will be able to send you an email with these resources. And let's see, one person has asked, is there a list of AA and NHPI serving health centers included in this report and number of AA and NHPIs served at each health center? And we can certainly get back to you. We will have to check with HRSA and the Bureau of Primary Healthcare, since this information is technically confidential, but we will certainly get back to you on this. Let's see, what other questions are there? And thank you, Vivian, for chatting in all the responses. One person has also asked, how do these percentages compare with Blacks and Hispanics, the Latinx community, as well as the uninsured and public insurance? Vivian has responded that UTS doesn't have uninsured and public insurance data by race. So therefore, we did a comparison between the NHPI serving health centers as a group to the national health center averages. It looks like I saw one person raise their hand. Let's see, Ingrid Hartman. I'm going to, oh, never mind, just kidding. Looks like Ingrid put, yeah, if you'd like to, talk or ask a question, feel free to raise your hand. All right, we have all right, we see a question coming in. So we have a large population of Vietnamese and Laotians and find that it is difficult to speak to Asian Americans about breast, cervical, and colorectal screenings due to cultural issues. Are there any resources that you would recommend on how to ask about and discuss the importance of these screenings without offending? That's a really great question, Ingrid. Vivian or Albert, would you like to answer that question?
Yeah, sure. I guess in our past experiences collaborating with other health centers, also with large Vietnamese and Chinese population, their strategy is to have several patient champions. They find it's much easier if a patient, can talk directly to the rest of the patient group on these issues, and their more open about this when a peer among themselves is talking about these issues to them. And also, I think that health center, they had education sessions involving not only providers, in language providers, but also in those education centers. In those education sessions, they included the patient champion as a liaison, and that was a great help to them.
Great. Thank you so much, Vivian. I also want to share with you, Ingrid, and to everyone else online today, that AAPCHO actually provides training on cultural humility, and how that is similar or different from practicing cultural competency. So if you're interested in learning more about cultural humility training offerings by AAPCHO, please feel free to email us at training@apcho.org. We'll drop our email in the chat box. Juliana asked a really great question. Are there specific provider recruitment strategies to ensure access? We also have expertise around workforce development in-house at AAPCHO. We do have some recommended strategies for provider recruitment and retention. We particularly are we can provide some technical assistance and information on programs like the National Health Service Corps, for example, the loan repayment programs for various providers. And I'm aware that there's a new HIPSA scoring that has been established this year. And we can certainly work with you and your statewide primary care office to assess your HIPSA score, as well as opportunities for changing that HIPSA score to ensure that you are a competitive health center so that you can have more providers being eligible for the National Health Service Corps. So Juliana, feel free to reach out to us if there are any other questions about provider recruitment strategies. Let's see, we have another question from Yvonne. This is, thank you, Yvonne. She says, this is an excellent study. Living in Hawaii, we have multiple Pacific Islander groups. Do you foresee your study looking at furthering data into this group? Also, do you foresee addressing mental health data? Albert, would you like to actually take a stab at this question? We actually have a special report focused on.
I was thinking that, Joe. Thank you so much. Yeah, Yvonne. So next month on January 21st, we are currently working on an additional UDS report just focused on Native Hawaiians and Pacific Islanders. Again, really focused on the UDS and some other data sources that really tell us the bigger picture and story around some of the health disparities that the Native Hawaiians and Pacific Islanders encounter and face these days in both the mainland and in the islands. So that webinar registration link will be made available in the chat box shortly, and so you can register for that, and the report should be released on the 21st of January as well. And in terms of mental health issues, that's something that AAPCHO is continuously trying to assess on kind of what we can do around that issue, since that is a need that health centers have expressed in the last few months. Actually, it's one of our top 5 issues, especially within the Asian American, Native Hawaiian, Pacific Islander community. And so if you have any ideas, we'd love to partner with you on kind of how we can address those on the national level. I'm not sure if you're at a health center, but that would be even more, I guess, relevant to the work.
Thank you so much, Albert, for answering that question, and great question, Yvonne. And I also just want to acknowledge we actually have, we saw in our attendee data, we have a lot of folks who signed on from Hawaii. So aloha to all of you. Thank you so much for joining. So, and as Albert mentioned, please save the date for January 21st, where Christine is, our colleague Christine just chatted in the registration link in the chat box. So feel free to register today, and so that you can learn more about Native Hawaiian and Pacific Islander serving health centers. Great. Okay, so folks can type in more questions. And you can also upvote or comment on specific questions. And we have time for one more question. We have a Hawaiian-born patient, but the children were born in California. When choosing ethnicity, do the children select Native Hawaiian or Pacific Islander? That's a great question, Martha. Albert or Vivian, can you help answer this question?
In our experience with other health centers, I think they have said it's more up to the patient, whichever race or ethnicity they feel more identified with. Albert, do you have other ideas?
Oops, sorry, I was on mute. Yeah, I was going to say the same thing, that's kind of a self-identified. I mean, most of the data that we also work with is self-reported. For example, in New York, in Brooklyn, there's a health center that AAPCHO has recently encountered and worked with, and how there is a huge Native Hawaiian Pacific Islander growing population in Brooklyn. But then when they talk to the patient, they're understanding that maybe these patients aren't, again, identifying actually with that population or ethnicity. And so it's hard to say kind of what push the mark. I would recommend, again, just working with those patients to figure out what they're comfortable with. And that's my perspective.
Great. Thank you so much for your opinions, Vivian and Albert. We have another attendee who mentioned in Florida, they go by what the mother's nationality is. So that's really interesting. Great. Okay, so I think that's about time for Q&A. I'm just gonna just share with all of you some next steps. If you're a health center serving Asian American, Native Hawaiian, and Pacific Islander populations, or a primary care association, or a government, or a CBO, please email us at training@apcho.org with your questions and any resources that you'd like. We are here for you. You're also welcome to visit our homepage. The link is provided there, as well as our homepage on enabling services. And we want to also highlight that in collaboration with 19 other national associations, AAPCHO has contributed resources into the Health Center Resource Clearinghouse, which can be accessed at healthcenterinfo.org. These are some additional helpful links. Our website, apcho.org. Again, please download the Enabling Services Data Collection Protocol at enablingservices.apcho.org. And there's a link there for S2H data collection. If you would like to contact any of us individually, here are our full names and the email addresses. So email us anytime, and we'd be happy to provide technical assistance or additional training. And with that said, on behalf of AAPCHO, we would just like to wish everyone a very happy holidays. And you'll see there that you can also engage with us through multiple social media channels that you see in front of you. Thank you so much for your time, for joining us. Thank you for serving the patients and really being mission driven and all the work that you do. And we will see you next time. So thank you and mahalo. Take care.